Good morning, good afternoon, good evening, good whatever time of day it is. Thank you for tuning in to Conversations with Dr. Don. This show is produced and broadcast from the Portland, Oregon, USA studio. And for your first time viewers, Conversations with Dr. Don is an ongoing series of 1 hour standalone talk shows where I interview interesting people like most of you out there about who they are as unique, one-of-a-kind individuals and about whatever it is that we have decided to talk about. And my guest this evening is Dr. Peter Marr, and thank you for coming aboard.
Thank you, Don.
Yeah,
Thank you for having me.
Betcha. How you feeling now?
Great.
Good. Yeah, you had away for a while. Before the camera started rolling, you were away with the family in the woods and away from television. How'd you manage? Yeah.
It's a nice break these days to get away.
You betcha, especially with the kind of work that you do. So let's go on with the first part of the show where we'll talk about who you are personally. And you've been on before, haven't you?
No, first time.
First time, heavens. I've had a bunch of you MDs on before with physicians for natural health care and so on. But okay, since you haven't been on before, I always have one or two trick questions that my guests don't expect, and they get a spontaneous response, and let's see how you handle them, okay?
Pressure's on. I'll see how I do.
And if I ask a question that you don't want to answer, you can just say, I don't want to answer that. And that rarely happens, you know. Occasionally I have somebody sneak in and I think they're one thing, and it turns out 5 minutes into the show there's something else. I says, uh-oh, I was snookered. Because I interview all kinds of people from left and right or whatever, you know. Most of the time I get people from the left or liberals or that political philosophy, and it works pretty well. And sometimes we even sing Kumbaya if we're that close together. Never mind my funny stuff. So, starting off now, if I were to ask your best friend, who is Peter? What would your best friend say? Pretend you're your best friend. Peter is what? Who is Peter?
Peter is a middle-aged man who happens to be a physician, lives in Portland, Oregon, has a family, a wife and 2 kids who are now already in middle school and high school, and he can't really believe it. The time is passing that quickly.
Yeah.
He does, obviously he works as a physician in the community, in a community health clinic, but he loves time off work as well, spending time with family, playing soccer, exploring on his skis and bike, and spending time largely with his family and friends.
But you don't have a lot of fat on you. You're nice and trim. How do you manage that?
I do enjoy exercising. I find that it's a good stress relief. I've always enjoyed just getting in a regular cardio workout and then doing a lot of outdoor exercise. Like I play soccer a lot, and I go hiking, and in the winter time going skiing, backcountry skiing. But on the other hand, I have to tell you a little secret.
Please.
Is genetics. I can basically eat whatever I want, and I won't gain any weight whether I exercise or not.
How do you do
but
that?
I still exercise.
We got to transplant
It's not my fault.
So you're fortunate, yeah. I'm pretty fortunate too, because I'm older and I managed to hold together pretty well. Thanks to a lot of people like you through the years that have passed me back together. And one was bionic, and we don't have time for a medical, so I'll tell you a little more about that later on when the cameras stop. And you were born when and where?
I was born in 1970 in Ithaca, New York, which is upstate New York, about 4.5 hours from New York City. Tompkins Community Hospital.
Remember that?
Yeah.
Yeah. Why were you born?
Where?
Why?
Why?
That's the last of the trick questions.
That's the parents. They have to answer to that one.
Okay, all right. Anything significant about your cultural heritage?
Yeah, my mom's family and culture is Czech, Czechoslovakian. She grew up in Chicago with a strong Czech community. And my father was born in Germany and immigrated after the war. He was a boy during the war, but he eventually got his education, and through education came to the United States and became to be a professor of physics. And that's why I was born in Ithaca. It's a home of Cornell University, where he was a professor of physics. And my mom and dad met there. She was also doing her graduate studies at Cornell. And they liked it and stayed. That's where I grew up. It's a nice place, upstate New York, Finger Lakes, a little bit of wine country, nice gorges and rivers, lakes.
I can picture it.
Yeah.
So how old were you when you left?
I left, I went to school there as well. I went to Cornell, and I graduated in 1992 at the age of 21. And I actually went to Czechoslovakia. And I worked there for a couple of years teaching English. Czechoslovakia was a Soviet country until 1989.
Yes.
And they had their quote-unquote velvet revolution, peaceful revolution. And after that, they were desperate for English teachers. So anyone could get a job, including me.
Couple of years.
Yeah.
Did you learn the language? Or enough to get by?
Enough to get by. Actually, I could speak pretty well in the social circumstances there. Unfortunately, it's probably one of the most difficult languages I've encountered, and I've lost a fair amount of it. I can still understand quite a bit, but speaking is a challenge.
Do you speak any other languages besides English?
Now most of my other language, aside from English, is Spanish. I work in a community health clinic, and a lot of my patients speak Spanish, and I had taken Spanish during my schooling, and so finally have a chance to use it. So mostly Spanish and English, a little bit of Czech.
Okay. And a religious preference, do you have one?
I'm not religious. Yeah.
Did you ever have a religious preference?
No.
Okay. Are you an agnostic, a skeptic, or?
I'm an atheist. Yeah, I don't.
You said the word.
Am I allowed to say that on community radio? We have to bleep that out?
I say, no, I am not an atheist. I am an atheist. There's a difference.
Atheist.
And you talked about your education, and you've been working at your profession for a long time.
Yeah, the reason I'm in Portland is that after medical school, I came here with my wife to do our training in Portland. She was at Providence. She's also a physician. She was at Providence, Portland, in internal medicine, and I did my residency at OHSU family medicine. And that's a 3-year residency, and then we decided to stay in Oregon. So I've been practicing in Oregon since 2001, if you don't count residency, which is 3 years. So.
Yeah. Do you like it here?
Yeah, I love it.
Need I ask the question?
Yeah.
You're such a peaceful countenance. Your eyes are clear. It's a pleasure to hang out with you and visit with you.
Appreciate it.
Yeah, betcha. Community practice, huh? Community, you see people who have anything that needs to be addressed by the kind of physician that you are.
Yeah, well, my setting where I've practiced for most of my career, when I first finished residency, I went into private practice in Corvallis with a group called Samaritan Health Services, which is kind of a larger group in the Mid-Valley. But the pull of Portland pulled us back within a year or two. And so after that, I got a job working for Multnomah County. And Multnomah County runs a large network of community health centers throughout, mostly Portland and even into Gresham. And so we have 8 primary care clinics, I think, and also 1 specialty clinic which treats people with HIV. And so I accepted a job at the easternmost clinic in Gresham, right near downtown Gresham, called East County Health Center. And I worked there for 10 years. Took a little break just recently and did some work with Portland State. I worked there at the Student Health Center and took some classes in public health, but then returned to the Multnomah County clinic system at a clinic in Southeast Portland, which is called Southeast Health Center on 34th and Powell. And that's where I work now.
If you had it to do all over again, would you choose a different profession?
Oh, that's a loaded question. If my mom's listening, I can't answer that one.
Pass on that question. You see, that's rare. And I ask a question that someone declines to answer.
I wouldn't necessarily decline to answer, but I think there's a lot of frustration with the healthcare system today.
Okay.
And I think that as you live your life, you do wonder whether it was the right thing. But I think in terms of matching intellectual curiosity, ability to talk to people and to help people, I think doctoring, especially in the community health center milieu, is a pretty good fit for me.
Yeah.
Should I have wandered? Should I have started in the Czech Republic and wandered around the world teaching English for years? Yes, I have those thoughts sometimes.
They're still there. We're back to, and you mentioned you have a partner, a wife.
Yes.
And children.
Yes.
And mention your children, how old they are again?
Philip is 13 and Jordan is 15.
Uh-huh. And no girls?
No.
When are you going to have a girl?
Still waiting. My wife is still waiting.
Okay, and well, you make a comment about your political persuasion on the political continuum: left, center, right, Tea Party.
I would say I'm a progressive.
Yeah.
Yeah, so more on the left, progressive.
Yeah.
Yeah.
I was tempted to ask you a question about the presidential campaign, but it's a nightmare. It's just a big entertainment thing on the television, huh? And memberships in political, social, or civic organizations, any of those come to mind for you?
Yeah, my main interest outside of family and work life is working with an organization called Physicians for National Health Program.
Yes.
I joined, we call it PNHP, which is easier to say. I joined PNHP in 2007, and I went to my first national meeting in 2009.
Uh-huh.
And after that meeting in 2010, started the Portland chapter of PNHP, and I still head that now 6 years later. At the time, there was a lot of interest because there was a healthcare reform debate going on nationally.
Yes.
And so there was a lot of interest in PNHP and our views on the process during that time.
Are we going to get a single-payer system in this country?
I think we need to. I think it's the only way to deliver better care to more people for less money. And I think every other industrialized nation has figured that out long ago and have single-payer type of systems that work well for them. Everyone is covered, comprehensive care, choice of any doctor or hospital, and affordable for not only individuals and family, but for the government and nation as a whole. And so we can continue on our system, but we'll never be able to cover everyone in a system that's affordable unless we get to some kind of single-payer system. So it needs to come. I believe it will happen, and I'm working hard to make that happen every day, either on a national level or even here in Oregon.
You know, I'm a card-carrying member of your organization.
PNHP?
Of course.
That's very good.
Yeah.
We need all the support we can get.
Yeah. Yeah. Persons from the past or alive today that you particularly admire or look up to, any names come to mind for you?
Well, of course, on the political spectrum, two quick ones are Gandhi and Martin Luther King. Is that too easy? I mean,
you sound like me. I always start with Jesus because I'm a recovering Catholic, because he was a socialist from way back anyhow.
Yeah.
And those other two are my favorite. Those are my three. So that's what I was smiling at.
Yeah.
Yeah. So
I once told someone in an interview for medical school that they had a similar type of question. I was a bit naive back then. I loved baseball and loved the Chicago White Sox. I inherited that from my mom, and I just couldn't think of anyone, and I shouted out Ozzie Guillen, the shortstop for the Chicago White Sox. The interviewer was pretty taken aback, and and kind of raised her eyebrows at that and asked me why, and I couldn't come up with a good reason, and I, of course, didn't get invited back, did accepted to that medical school, but yeah.
So why did you look up to Gandhi and Martin Luther King? What is it about them that you look up to or admire them?
I think it's really the manner of change coming from peaceful strength, and I think it's probably the bravest way to create change. To create change by standing up to what is wrong with no arms, with nothing but your body and your heart in a way. And I think that when that form of political resistance takes shape, the authorities that be have a very hard time dealing with it. Yeah. I think right now to kind of the Israel-Palestinian conflict, and I think that often devolves into a violent kind of conflict. And I think as a resistance, there's a lot more strength in peaceful resistance. I think there's a stronger resistance, and I think the people in power have a much harder time dealing with that. So I think that Gandhi and Martin Luther King did that very well.
Oh yeah. How did you come to that sort of a view of life and humanity and philosophy? Where'd you get that from? Your mom, your dad?
I don't know. I think probably from my parents, life experience. Yeah, I can't really say reading.
Yeah.
Yeah.
You know any other people like you?
Maybe there, I mean, yeah, I'm sure there's many of us.
In that context, of course,
yeah,
you know, caring about human beings and believing in justice and fairness.
Yeah.
And being kind.
I think that that's a fundamental value in the United States that's underplayed. I think that we have a long history of that, with many movements that have been successful, from union movements to the women's suffrage movement, to current movements with gay marriage issues and other things. I think we have a social insurance system that's widely accepted and popular, both in Medicare for healthcare for people over 65 and for our Social Security system. So, I think those types of systems are highly valued in our American tradition, but are very undervalued in our media right now, in our public discourse. So I don't think it's unusual. I think that that's an American value.
A brief digression. Have you seen Michael Moore's new movie?
No, what is it called?
Who Do We Invade Next?
I have not seen it.
It's phenomenal. The reviewers gave it only about a 55 or so, but it's just, I'm going to see it again. It comes to mind now because we're talking about what's going on in other countries by way of justice and treating their citizens. He travels to different countries and talks to in each country he talks about the people in that country, about something unique about that country that is going on in America that's completely different than what's going on in Germany or even in North Africa like that. It's just a phenomenal thing. And the movie's as good as anything he's ever done. And I think you'd appreciate it. And,
I'll look for it.
I can't talk about it enough. Yeah, it's playing locally too. It's playing wide distribution. So much for my digression. So we can go on into the second half if we take an early break and talk about community health.
Sure.
Can we take a break early, Mr. E, our director? in conversation with us.
Yeah.
Occasionally I have a guest who's fascinated with
Yeah.
the image on the
Get 'em
screen.
there,
So anyhow, thanks for staying tuned, and we're back. And for you viewers who missed the opening of the show, Conversations with Dr. Don is an ongoing series of 1-hour standalone talk shows where I interview interesting people like Dr. Marr here. And then we're talking about community health and related subjects. So let's go on in the second part of the show. And I've got a series of questions I can ask you to prompt a discussion, unless you want to volunteer something that we should talk about.
No, I think that's fine. And we named this kind of conversation community health.
Mm-hmm.
Even though I'm a physician who's taking care of individuals, each in their own exam room throughout the day. But I think over time, when you do that for years and years, you realize that you can't separate community health and individual health. And so that's why I thought it would be nice to talk about community health, and maybe we could just explore that kind of notion first of how, as a physician, you come to that realization, maybe.
So community health is equally as important. No, there's no really separating the two, is there?
Exactly. And so when you practice day after day and you see people with high blood pressure and suffering from addictions or chronic pain or diabetes, many of these illnesses, especially chronic illnesses, have their roots in the community, whether good or bad, especially with issues surrounding addiction and abuse and trauma in people's pasts. And so when you start to practice years and years, you realize that you really need to start looking more upstream, and you need to figure out what's going on in the community, and make that connection between community health and your actual healthcare system.
How do you know more about the community? Is it just through the patients you see, or there's some other effort you make to get an idea about community health beyond just the patients that you see?
Well, I think just anyone who lives in their community can see whether can kind of put the pieces together. And so if you can't figure out why someone's diabetes is difficult to control, and then you realize that they don't have enough food to eat every month, they're scrambling for food, or if they don't have a roof over their head, it's very difficult for them to concentrate on their individual health and eat right and exercise. And I think the way that we've constructed our society and communities has a lot to do with chronic illness, and then that ends up in our labs, and we're expected to manage it. Whereas really, I think you can do the best you can to help people with their medical issues, but if you neglect the community health piece, you end up spinning your wheels.
And how well can you, as the physician, manage their health? How well can you manage, considering what the patient is going to bring to you for you to deal with as you care for their physical ailment?
Yeah, and so what you end up doing is you end up doing the best you can within the clinic setting. And I must say that, especially at Multnomah County, I know other clinics and community systems like Kaiser and other things, they put a lot of emphasis on preventative care and looking at other factors that affect people's health care. And especially in the last 4 or 5 years, I think, in Oregon with community care organizations, other things, people are looking at these upstream type of issues that affect people's individual health. And so we have community health workers and other people who can reach out to people in their community and make connections in the community to help with these other issues that are affecting them. While I do my practicing kind of in the office, we can kind of start to reach out.
Of course.
And there's other clinics around the country, and I think you just learn through my own interests. Like I said, I took a little break from practicing primary care medicine and took some classes at Portland State University in public health, and really looking at something called social determinants of health. So what are the social and economic and other factors that affect people's health on a population level and also individual level? So I have that interest, and what I think that interest came from spending years in a primary care clinic setting, dealing with a lot of chronic medical conditions that I felt reflected less about the individual, but more about the community and the society that we're living in.
So can we, as a society or as a culture, do something to have a better outcome and have a healthier community?
Well, there's many things that go into it. I mean, take for example, we'll just take one example. We'll look at this quote unquote obesity epidemic.
Okay.
Okay, if you look at statistics now, 60% of Americans, the great majority, are either overweight or obese, according to body mass index numbers. And if you can look at that in two ways, you can look at it as an individual issue, and that's what we like to do in the United States. Always look at the individual and the individual responsibility. And you can ask people to diet and to lose weight and to exercise more, and they do the best they can, and they often fail. Or you can look at it as a public health issue, which is what I like to do. And you can go all the way to, for example, our food manufacturing system. We can go all the way to corn production and corn subsidies, and the fact that we're spending a lot of money, in fact taxpayer money, producing corn, which goes into our food system either through beef production or corn syrup, and corn syrup is put into many foods.
Oh yeah.
And so people a lot of times don't have control over it, especially if you don't have a lot of money to purchase your food. Don't have control over this buying foods in this kind of food system. And then you can go to the transportation system, which is mostly fossil fuel based, and less around creating communities in which people can walk and bike. Portland does a better job than other places, but I think we can say that in general in the United States we have a difficult time with transportation systems. We don't have train systems, high-speed train systems, local public transportation that works as well as it does in other industrialized nations. And so you can kind of start to look at all of these other factors, and you realize that we've created a society where people become overweight. And you almost, as an individual, to counteract, you have to swim upstream. You have to fight to maintain a healthy body and active body, because these forces are acting against you. And then that's what Thomas Frieden said. He's the head of the Center for Disease Control, CDC, basically the top public health officer in the country. He says public health is about creating a society or a context so that people make the right choices. And right now we've created a society where people have the easiest choice is the worst choice for them in terms of health. Yeah. So I don't know if
You're doing
explaining?
fine.
Okay.
You're doing fine.
Yeah.
My questions sometimes are a little probing, and I'm not sure where I'm going, and I like where we're going.
I think with my answers I'm also meandering a bit, but I'm trying to get that point across, that
and you are.
That these situations kind of in your office they're much broader. The context is so broad.
Yeah.
And so to make those changes, some of those changes are incredible changes. I mean, we could look at income inequality, housing, food systems, transportation systems. All of that is public health, but it creates a healthy situation for people and then would reduce chronic disease as a whole.
So there's what you can do collectively with your organization and in your practice, and then there's what you can do as an individual human being dealing with your patients. And I don't presume to have any idea what's going on, well, any serious idea about what's going on with somebody's physical health, but I'm an educated man and I've been around for a while. But I think about my own practice, and I still have a small private practice and office in my home. And I think back on a few fairly recent clients that I've had some success in having them overcome whatever the influence is out there to have them behaving in an irresponsible way toward their overall health, not just their mental health. And I've seen changes, and depending on how persuasive I am and how ready they are to change as to how much they will change. And if there's some improvement, some awareness, and I can see the result over a period of time seeing them, and I say, like this person does not do marijuana at all anymore, or doesn't do alcohol on an ongoing basis as a means of having some respite or some peace from the stresses going on in their minds. So, and then if I'm successful with this client will then behave differently with other people that he or she is interacting with.
Yeah.
And it's a tiny bit. It's like wearing my signs, but I'm doing something. I got to do something.
Yeah.
Yeah. And I love my work.
Yeah.
And sometimes I'm not supposed to take it to bed with me, but sometimes I take, on rare occasions, take it to bed and say, "Now get away from that. You can't do that." And I'm pretty good at that. Anyhow, I'm talking about me now. But I appreciate what you're doing. And one more personal question.
Yes.
Bedside manner. That's so important.
Yeah, I think it is. I enjoy that part of it, though. I think that's the nice part of practicing medicine, is that everyone that is coming in front of you is a person, and you don't blame them and they don't judge them. You treat them, you give them advice. You also don't try to take over their health. I think over time you realize a lot more that someone's health is in their hands, and you're their advisor and their supporter. But you're not the one that's going to quit smoking or stop drinking or start exercising every day. But I think the real joy in medicine, especially practicing in family medicine, is watching people over time. You have a relationship with them, and that's the fun part. And seeing people over time, it gives you a sense of a real satisfaction and connection. Mm-hmm. So bedside manner for me, I mean, just it comes pretty naturally. Rapport with people, interacting, being supportive. There are pressures. There are time pressures, and there are stress pressures.
Time pressures.
And so sometimes you have to work hard to maintain it, or always to kind of go back and put yourself in someone else's shoes. And realize, especially when people are sick, they're pretty vulnerable. And you just always have to remind yourself of that, too.
Well, the Physicians for a National Healthcare Program would do something about those things you're talking about now that could be better in order to have a better outcome, like limiting the amount of time that you can spend with the patient. Yeah,
I mean, I think the time pressure comes from some of this payment system, but I think it also the connection with people over time is disrupted by our current system. Our current system works almost hard to interrupt the patient's relationship with a certain doctor or a clinic. The relationship between a person and their doctor or their clinic or their hospital is regulated or dictated mostly by what type of insurance they have. And now insurance is changing so rapidly from year to year, or from paycheck to paycheck, that I'll be taking care of someone for 3 months, and then I'll find out 6 months later that they're in the Kaiser system or they're in the Providence system. And maybe 6 months later they'll come back to see me. I had a patient who was a new patient coming to me with really, really high blood pressure. Mm-hmm. She was in the age group where it was even a risk for her to have a heart attack or stroke. It was that high. Yeah. And she had said, well, I had great care for years at OHSU until my husband died, and he carried our insurance. I lost my insurance. I haven't had insurance for 3 years. I haven't seen anyone. And then she was seeing me. So our type of healthcare system, which access to care and continuity of care is dictated by insurance, is very disruptive to that patient-physician or patient-provider connection. And so under a national health program, or you have a kind of a single-payer system where you have one comprehensive set of benefits for everyone, you don't need insurance. Everyone has social insurance, that's healthcare insurance.
No insurance? Are you anti-insurance?
No private insurance. We don't need them. Okay. They're just paying the bills. So funnel all the money that's paid for private insurance and Medicaid and Medicare into one pot, figure out a fair fee schedule for providers, clinics, hospitals, specialists. Person can have that comprehensive set of benefits. They can visit any doctor or hospital, and that doctor or hospital gets paid out of this pool of money. It's more efficient. You have better comprehensive care. You have continuity of care. You have excellent care. And you have happy doctors and happy patients. At least happier than in the United States.
And Michael Moore talks about that in his productions and like that, those kinds of things we're talking about right now. So why is it that it works in those other countries and it doesn't work here? We don't have it here. Why is that?
I think that's the $1 million question, right? That's your job, right, as a host, huh? To ask this. You know, I think there's a variety of reasons.
Okay.
I think that history takes its part. You know, it never really happened. In other countries like Canada, the concept of creating this type of healthcare system, kind of a universal healthcare system, happened and was driven forward and worked in one province and spread like wildfire to the rest of the country. Mm-hmm. Germany goes way back to the 1800s with Bismarck, feeling like this was an important thing for the citizens of Germany. And then other countries have it written into their constitution. So historically, we didn't really ever have a plan to address the issue. And the system we came up with has evolved over time. There's a few types of, we have every type of healthcare system here in the United States. We have single payer in Medicare. That's a single payer system. We have private insurance systems. We have military healthcare, veterans healthcare, which is a socialist system. So we have bits and pieces from all these other industrialized nations around the world. But what they do over there in these other countries is they pick one system, and they go with that for everyone. And if you start having different systems for different people based on their income or their military status, or whether they have a job or not, or whether they're poorer or richer, or whether they're older or younger, then you create all these different pools of people, and they have different rules for each pool of people in terms of insurance. And once that starts happening, things get very expensive very quickly, because the administrative complexity is just astronomical. And so it adds a tremendous cost to just administering the system of insurance, and it adds a tremendous cost to doctors and hospitals. There's stories told about Canadian hospitals where their billing office is one office or two offices, 2 or 3 desks, 10 people. And then you go into, for example, in Montana, borders with Canada, you go into Montana to a hospital there, and the whole floor of a hospital is for billing. And so you get that sense that we just have this immense, complex, very costly system, where other countries have really gone towards focus on comprehensive care, easy access, no co-pays, no deductibles, and negotiating fees and making everything very efficient, reducing administrative costs.
Well, you're talking about health care versus a business and a profit motive, those kinds of considerations, rather than treating a human being and making them healthy and not having these other interferences that I gave up dealing with the insurance industries a long time ago when I moved from California to Oregon. And my people pay me across the board, but I don't file in the paperwork at all.
Yeah. And
I shut my practice down years ago.
Yeah.
So that's what I've done with the insurance companies.
Yeah. Yeah. I mean, that's one way to deal with it, is that paying cash. But then, of course, if someone has, in terms of a motor vehicle accident or has cancer, that falls out the window when you're spending $100,000 on a 10-day hospital stay for a motor vehicle accident. Cool. So it is a type of healthcare is a type of thing where you do need to be insured. If something bad happens to you or someone in your family or your next door neighbor, you want them to have good medical care, excellent medical care, but you don't want them to lose their home or their livelihood because of it. And that only happens in the U.S. No other industrialized nation has a healthcare system where just because you happen to get in a car accident or you had cancer, that you would lose your home or livelihood or go bankrupt. And again, it goes back to that, what you said, what is the priority? And I think really these other nations have looked at healthcare as a community good.
Community good.
Just like education and a fire department, policing, utilities. They regulate it and they provide it, not only because it's the right thing to do, because like I said, if you're sick and you get cancer, you shouldn't go bankrupt, but also because it's a benefit for the nation as a whole.
But that sounds like socialism.
Well, there's a gentleman who came to talk we hosted him as a PNHP group. His name was Ted Marmer. He's out of the University of Yale University. Mm-hmm. And his work has been in Medicare and other, what he calls social insurance systems. And he says, we've lost the discussion, or we don't have the discussion anymore about insurance and the difference between commercial insurance and social insurance.
Oh, okay. I never heard it phrased that way.
Yeah, and it's an interesting way to phrase it, because commercial insurance in terms of auto insurance or even life insurance, it acts in a very different way from social insurance, Social Security, Medicare, and these other nations. Kind of a healthcare system, we have a social insurance system. It's treated as a community good. You create a system that's universal, comprehensive, and affordable. And we haven't done that here. It's treated more, like you said, as a business. Mm-hmm. And more people are making large amounts of money on it.
Let's see what other questions we have here. Do you see health as including physical, mental, and spiritual health, whatever you consider spiritual health to be? Does health include physical, mental, and spiritual health?
Yeah, and you see that every day in the clinic. I mean, there's such a strong connection between someone's emotional health and their past history of what they've dealt with in their life and their current medical problems. Okay. Chronic pain is a perfect example. People who have had trauma in their lives are much more likely to live in chronic pain. People who are depressed, much more likely to live in chronic pain. Mm-hmm. And vice versa. People who have chronic pain are much more likely to be depressed. And so you really have to pay attention to people's emotional states, their mental health, as well as their physical health. And you can really separate them. They're intertwined.
Of course.
And that's kind of an interesting, and I think almost, I don't want to say exciting, that's maybe not the right word. Exciting thing about medicine is making those connections for people, because oftentimes they don't realize it. And when you can sit down with a patient, surely you evaluate their pain and you work it up and make sure you know kind of where that pain source is coming from, and make sure you're not missing anything that could be treated. But then another part of it really is looking at their context, like we talked about there, their community context, their family context, their individual emotional context, their stress levels, mm-hmm. their whether they suffer from any mental illness, and connecting those physical and mental kind of illnesses or situations, and improving not only physical but emotional health together by doing that is it's not exciting is not the word I'm trying to think of. It's
empathetic.
You're using empathy to do it. It's satisfying. It's very satisfying. It can be can really engender that physician kind of patient connection.
And I think there's something that goes on between me and my clients and my patients that's beyond what we register up here. That's where the spiritual thing comes in. And if I'm really connecting with my client and listening with all of my senses, and they're aware that I'm really listening and interested in them, at some brief moment there's a connection there, and that's dependable, and that person will be invited to get healthier because someone really cares. This is beyond what's going on here. You know, I don't go too far out here like one of my daughters in spiritual stuff, but I think that works. And to see the result of listening to somebody and being really interested, I'm talking about mental health now. My primary I got mad at him a couple of times through the years, but I waited a while and it passed because he's still a human being. But he's thin like you are. He's a trip, and he rides his bicycle all the time. He's just a delightful human being. But you're talking about me again. I love the work I do. And I have a sliding scale, thank goodness, because I don't have to pay overhead for my office work. And some insurance companies, my clients insist, and if they do the paperwork, I go along with it. And they still get paid. You know?
Yeah.
Will you cite the community health of other countries as compared to ours? And we talked about that a little bit, and what we need to do to improve ours. And what do we need to do to improve our health care system?
Well, I think there's two questions in that statement. They're looking at what do other nations do for community health and the connection to the healthcare system, and what do we do here? And there's a distinct difference. And we already talked about other nations having universal care systems that treat healthcare as a public good, whereas we tend to treat it as a commodity. We even use this language around consumers. When was the last time my patient was a consumer? You know, consumers of healthcare. So we even use this business language. Whereas other nations, they provide it as a public good. They make it affordable and efficient, comprehensive. But in doing so, the amount that they spend on healthcare is a lot less than ours. So if you take we always use the Organization for Economic Cooperation and Development, OECD. These are basically wealthy, first world industrialized nations like ours. So when you compare, you can look at OECD statistics. And if you look at per capita healthcare spending, OECD countries spend on average a little less than half of what we do for their healthcare. Per capita, it's even, I think it's somewhere around $3,000 per person, and for us it's $8,000 per person. So almost 3 times actually. So we have a healthcare system that, because of that, uses up almost $1 in $5 in our economy, about 20% of our GDP. In these other countries, it's about 10% of their GDP.
Is it because of the kind of capitalism practiced in our country?
It's because of the way our healthcare system is set up, and that administrative cost that we talked about before, the complexity and cost, and shifting people around into different systems. And if you lose your job, you're into one other system. And if you're poor, you're in one system. But then if you make money, you're back into the private insurance system. And then if you turn 65, you're in the Medicare system. And the insurance companies being involved with their thousands of different plans. And then all of these different other plans, even Medicaid, having to guarantee that you don't make too much money so you can have Medicaid. You need people to evaluate that and to look at your pay stubs. All of this complexity, and also not having one unified system, you don't have the ability to regulate and negotiate prices. So you have very high prices, very high administrative costs, and suddenly you're spending $1 in $5 of your economy. In every one of these other countries, they're spending roughly $1 in 10. And the interesting thing about it is, what are they doing with the dollars that they save? These other countries are investing in public health, preventative health. And when you go back to that concept of social determinants of health, factors in people's lives and communities and society that affect their health long term, and you take a little graph, a pie graph, and you say, okay, how much of someone's health is related to the healthcare system itself? And how much of their health is related to genetics, environment, context, society? 10% is related to the healthcare system, small piece of the pie. A large percentage is genetics, but then all the rest, a huge percentage, is their context, their society, their social determinants, public health. And so we are spending all of our money on this little piece of the pie, and these other nations are spending a smaller sliver on the healthcare system and a much bigger piece of the pie on social determinants. So they have systems in place like 1 year of maternity leave, paid maternity leave with guaranteed return to work in European countries. They have paid sick leave. They have a lot of these programs in terms of early childhood development. Moms, families, young children are supported.
You got to see that Michael Moore movie, I promise.
Yeah,
It's right what you're
it's probably making a similar point.
Yes.
And so
yes.
what they're doing is they have an efficient, comprehensive public good of a healthcare system when people need it. But what they're really focusing on is these upstream issues, creating a healthy society with good transportation systems, healthcare systems, public health systems, food systems. If you look at Norway and the United States, we spend the same amount if you combine the two, public health spending, social spending, public health spending, and medical spending. You combine those two pots, we spend about 25 to 30% of our economy on those, both countries. In Norway, they spend 1/3 on their healthcare system and 2/3 on all of these other systems, social spending, public health spending.
Yes.
In the United States, it's reversed. We spend 2/3 on just our healthcare system and only 1/3 on all of these other social determinants or public health social spending.
It's a losing proposition.
And then you look at the healthcare outcomes. Our healthcare outcomes are much worse on a population level in terms of infant mortality and other basic statistics of population health. It seems to be written on the wall. I mean, you don't have to go very far to find these answers. Which circulates back to your question then, why haven't we figured out? And I think then that becomes the $1,000,000 question. I think then you have to go all the way to the political system and how the political system works.
Be careful, you're involved in
We'll have to go ahead and edit that out, huh?
You mentioned that you like Bernie Sanders, so you're really on somebody's list now.
Well, I think Bernie Sanders is making that connection between investing in general population, not on the limited few that kind of have all the wealth and power, but creating an economy, creating a society that works for the common good. And that's what our P&HP is for in terms of a smaller version of that, the healthcare system within that context. We're looking at treating healthcare as a common good, as something to invest in that will not only help individuals and families who are using the system, but will help our public health as well. So.
Oh, man. Why is ours not the best? And we talked about that. What must we do to believe it is near the best, if not the best? What must we do to have things change? What you're doing with your organization, and what else must we do as a society, as a culture, as Americans, to have the health care that we need to have that's optimal?
Yeah, I think the interesting thing about our healthcare system is that we have I would argue the best trained doctors, nurse practitioners, physician assistants. Great training. We have great equipment. We have great hospitals. We have great nurses. We have highly educated, well-trained professionals within the healthcare system. We have great technology. We have great abilities.
Yes.
In Oregon itself, we're working on community care organizations. We're working on delivery of care, medical care homes. All of these designs on delivering care and making the care that people get quality, and working on healthcare outcomes. But what's happening is that is undermined by this very complex, unworkable insurance financing system that we have. So no matter how much effort you take to create a medical home for someone, if their income goes up and they switch to private insurance, then they're out. They're in some other kind of system because that private health insurance system doesn't have you listed as one of their providers. So you can do all this work, and we can train all of your doctors and providers, and you can have great equipment and technology. But if you don't have a system that works well for people, that's efficient and affordable, and not complex and bureaucratic, then all of that is undermined. So I feel, and Physicians for National Health Program feels the same way, is you need to fix the financing system of your healthcare system first, before you can do anything else. Unfortunately, what we're trying to do is fix everything else besides the financing system. And we can't figure out why we can't save money and why we don't have better healthcare outcomes. So I think the key is fix the healthcare financing system.
How do we do that?
Take all of the money that's invested in our healthcare system, the taxes we pay into Medicare and Medicaid, and into the military system. Take all of the premiums that are paid by employers and employees into the private insurance system, and move it into one pool. And that pool simply pays the bills. And every patient can go to any hospital, any doctor, any clinic system. It's accepted, and any visit is paid through this one pool.
We have to figure out how to do that.
That's what other systems do. That's what Medicare does. We could simply take Medicare and expand it to the whole population, improve it, and we'd be done. It wouldn't be that difficult. So that's technically what needs to be done. And these other nations have shown us, as I said, it's not rocket science how they do it. There's an author, T.R. Reid, out of Colorado. He's written a book called Healing of America.
Healing of America.
He goes around to all these other nations around the world, analyzes their healthcare systems, comes out with the 3 truths, which are one universal system for everyone, very low out-of-pocket cost to improve access to care.
We got about 30 seconds left.
And not-for-profit systems. And it works for them. So it's not rocket science. Everyone knows that what we need to do. We just need to get it done. And then everything else will flow after that.
Tell our viewers one final word. You have about 15 seconds. Tell them something.
Go to OregonPNHP.org, click on the donate button, and sign our resolution in support of universal, publicly funded health care in the state of Oregon. Thank you.
Thank you very much. We got it all in. Do we have time for a public service announcement, or is it all worn out now? To watch my shows on the web, Google Don Baham YouTube, and you'll see me talking to some other people nearly as interesting as my doctor friend here. And the ACLU, you're going to tell us about the American Civil Liberties Union? Yes, our civil liberties are seriously in jeopardy now. Go to the ACLU and learn how to join it and help save our civil liberties. And now I'm going to have to say goodnight because the time has run out. And I got to, of course, remind you of the Watching My Dr. Don series. That's enough. KFC, kind, friendly, and charitable. Be kind, be friendly, and be charitable. Thank you, and good night.